Many of you know me in a professional capacity, and some of you know me in a personal capacity as well. However, there is a long part of my journey that some of you don't know about as yet, and that is prior to my arrival at Stellenbosch University in 1995. So, I've had a long journey, a long, complex, exciting, and challenging journey. And so far, I've enjoyed it. To start off with, I think I've been genetically tested. So my genetic tests tell me that I am of Indo-Asian origin. Historically, I'm a fourth generation South African. My ancestors came to South Africa from colonial India in the 1860s, and they were brought here to work as indentured laborers on the sugarcane fields in Natal. Much of the detail of this interesting part of my history is to be found in the book, Inside Indian Indenture, by Ashwin Desai and Vahid. And I'm sure you will have great enjoyment in catching up with the story of the Indian immigration to South Africa from as far back as the 1860s. We grew up in Durban, and during the course of our early lives, we lived under the constraints of a number of interesting laws during a part of our history that is referred to as apartheid. This indeed was a very interesting social experiment. As a result of the Group Areas Act of 1950, my family and I were compelled to live in an Indian area. And of course, in the year of my birth, the Indian Education Act of 1965 meant that I had to go to an Indian school. Of course, at this stage, given that the medium of the language of education in all the schools in the areas where we lived was English, my parents decided that they would stop speaking to us in our vernacular and spoke to us in English so that we would fit in more easily in terms of the education system. So although I lost my home language at birth, I continued to follow traditions in our culture, and I was raised as a Hindu. When I started schooling, however, I attended a Catholic school. And that was interesting. It was the St. Anthony's state-aided Indian school. And I'm pleased to say that my brother Quresh was at the same school. And Dr. Leila Raja, who's sitting in the audience, was at that school, and so was our very own Professor Suraya Sidat. In fact, she and my brother were in the same class in junior school. So during the early years of life in Durban, as a child, I remember going to Mitchell's Park with my dad, and I was told very clearly which benches I was allowed to sit on. And as you can see, we had to sit on the green benches. High school was at the Chatsworth Secondary School in a very low-income area. Our school fees were all of 2 rand a year at the time. But we had the most outstanding teachers, and I had a wonderful high school education. Of course, from this point onwards, it became quite another unique type of experience to attend the University of Natal Medical School. Now, this medical school was founded in 1951 by 2 doctors, Dr. McCord and Dr. Alan Taylor. And it was founded specifically to train black students. So like my dad before me, who had attended the Fort Hare University in the Eastern Cape, also a black institution, I attended the Durban Medical School, which was the only black medical school in the country. And it was described as an anomaly in apartheid's grand design. And that is so because it was the only black faculty in a white university located in a white residential area. That meant that the students had to live 20 kilometers away in a colored area called Wentworth, in a residence called the Alan Taylor residence. And some of you in the audience spent all 6 years of your training in that particular residence. And so you will remember only too well that it was a World War II barracks. It was located next to a foul-smelling oil refinery in Wentworth, and some of our colleagues took 4 buses a day to travel to and from university. Our first year of training was located at the Alan Taylor residence as well, and we often incurred the wrath of a professor of chemistry called Mr. Paris, whom some of you will remember only too well. In fact, many people in this faculty will be surprised to hear that he induced the worst form of terror into me, the worst form I think I have ever experienced as a medical student. In fact, Bongani Mayosi, who is going to be the new dean of the Faculty of Health Sciences at UCT, was in my class. And he often reminds me of the day I looked up while carrying a set of glass test tubes. I looked up and I saw Mr. Paris. My hands began to tremble, and all 10 glass test tubes came crashing to the floor. You can only imagine the profanity he uttered after that event, and my colleagues remind me frequently of that day. However, the rest of our training took place at the medical school campus in Kongela, next to King Edward VIII Hospital. And it was a wonderful training ground. We had the most outstanding lecturers, and we trained under rather difficult conditions. In fact, at King Edward VIII Hospital, in the 1980s, we had floor beds. And I think that's a phenomenon that is largely unknown in many other parts of the country. So what are floor beds? Well, we had patients on every proper bed in the hospital, and then beneath each bed on a mattress was another patient. And then in the corridor of the ward were 2 rows of mattresses on which patients slept for the night. And those were the conditions under which we worked at King Edward VIII Hospital. So we did our ward round on the beds. Then we did a crawling round on the floor and the corridor. And Dr. Fatima Basa, who is here, will remember that, as will Prof Elvis Irison and all my colleagues who are here this evening and who trained with me. Now, I worked in the Department of Medicine for 3 years after graduating, first at the R.K. Khan Hospital and then at King Edward VIII Hospital. And of course, many of you will know Professor Y.K. Sidat, who was head of the Department of Medicine and who is a world-renowned expert in hypertension. He's still around because I've seen him on LinkedIn. So, what was really interesting about Professor Sidat was that he was always up to date on the latest literature, and he kept us on our toes. The most interesting thing I discovered recently about him, in fact, in the book on the medical school in Durban, which is written by Vanessa Noble, A School of Struggle. The most remarkable thing I discovered in this book about him was that when he was a registrar in training, he earned only 65% of the salary of the white registrars junior to him that he was training. And as he quotes, as is quoted in the book, he said, "I was told disingenuously that my standard of living was lower than that of the whites." He went on to study renal medicine at the Royal Infirmary in Manchester in the UK. And when he came back, was told that he could not work in the renal unit in Addington Hospital because it was a white hospital, there were white patients, there were white nurses, and under no circumstances could he be giving instructions to white nurses. Of course, the situation was to change a few years later, and we all still remember him as the debonair head of medicine at King Edward VIII Hospital and the University of Natal. So, did anything good come out of apartheid? We were the guinea pigs in that experiment. Was there a pearl in the oyster? I think there was. We know that apartheid is unethical in every possible way conceivable. However, we learned an important lesson, and the development of resilience was that lesson. So we've all heard about IQ, intelligence quotients. Most of us were measured when we were in school, and that tests only our cognitive abilities. More recently, we've been hearing about EQ, and that's our emotional intelligence. And some people have a very high IQ and a very low EQ. Others have both high IQs and EQs, and that's wonderful. There's another quotient called the sentience quotient, SQ. The most important one, however, as a predictor of success is the adversity quotient. And depending on how resilient we are in the world, we are able to cope with all kinds of adversity. Many of us, and many of my colleagues in the room with me, who struggled through Alan Taylor residence and the training at the Durban Medical School, which was excellent academically, but which took place under circumstances of deprivation, actually succeeded in spite of apartheid. And I think that is how we stand here today in all our various positions of success. But racial discrimination was just one part of the challenges we faced. One of the challenges I faced as a person in medicine. Being a woman, however, brought with it its own set of constraints. So, as you can see on the graph, there are three periods in my career when I would have been expected to publish, and they are all equivalent 8-year periods. You will see that from 1990 to 1998, I only managed to publish one article in the South African Medical Journal, and that was when I did my master's in family medicine. And that particular publication was about the constraints that women doctors face in medicine. But correlating with that period, I had 2 sons, and I spent much of my time raising my sons. I also worked as a doctor in the public health service, and so as a joint appointment member of staff, I worked non-stop. So I remember one day that Prof Pierre de Villiers said, we were in the family medicine department, and he said, you shouldn't take the lift, you should walk down the stairs. You need the exercise. And I said to Pierre, I'm taking the lift to conserve my energy, because when I go home, my second job starts. And of course, this is how we managed, and this is for all the women in medicine, and all the women in health sciences, is that we often had to juggle being at work, juggle being a mother, and juggle the demands of a challenging career. So achieving work-life balance was one of the most difficult things we had to do. It was also a challenge in that there were no full-time positions for training. There were only full-time positions for training for registrars at the time. The one exception, however, was family medicine. And although my first love was internal medicine, I found that I had to find another home for myself. And I was very fortunate to find that home in a wonderful discipline called family medicine. Of course, I joined the department in 1995, and Professor Davy van Velden said at the time that the only reason he accepted me onto the program was because I was a dancer. Of course, I had a wonderful journey in family medicine. We learned about complexity, and systems thinking. And systems thinking is a really old theory that dates back to World War II. However, this was one of the mantras that we learned from Dawie van Velden. He had a very different approach to our postgraduate training in family medicine. The book by Stephen Covey that you all probably know very well, The 7 Habits of Highly Effective People, was a prescribed text for the course. And I read every page and I highlighted the book completely. It was the first time in my life that I learned how important it was to say no. That the more we took on and overburdened ourselves, the less well we functioned in the various roles that we had to play. And of course, learning about interdependence and the ability to prioritize was incredibly important. Dawie was really forward-thinking. I didn't realize how forward-thinking he really was until I registered for my MBA in 2013. And as part of that program, I once again was introduced to systems thinking. And then I said, hang on, this is nothing new. The MBA program is actually a bit outdated because Dawie has been teaching this for the past 15 years. I was also introduced to a philosopher called Roy Busker, who was a student at Oxford University, and who developed a theory called critical realism, which is quite complex, and I'm not going to explain the details at this point in time. But what it is in a nutshell is that there are 3 important domains in life. The big outer circle, as you can see, is the real world. It's where everything happens, where there are events and experiences and mechanisms that result in these events and experiences. The second circle, as we move further in, is referred to as the actual domain. And these are the actual events which have been generated by various mechanisms in the real world. So these actual events, some of them are observed by us and others are not. It's the smallest circle that we focus on in health sciences and in other scientific disciplines, the empirical world. And as you can see, the empirical world comprises only those events that we as humans actually observe. So much of our science is based on a reductionistic type of thinking, the so-called Newtonian approach to thinking. And as we can see from the HIV/AIDS pandemic, the science is just not enough to solve this major problem globally. There are many other aspects, many other mechanisms, human behavior, social sciences, ethics, that all influence how we are going to be able to solve this challenge. And so focusing on the science alone is not enough. And those of us in family medicine know this only too well. As much as I enjoyed my journey in family medicine, there came a point when I had to move on to bioethics. And for me, the Robert Frost quote rings ever true. 2 roads diverged in a wood, and I took the one less traveled by, and that has made all the difference. At the time, I thought very seriously about bioethics, and at the time, it was a completely undeveloped discipline. And I figured there are enough doctors around to treat hypertension, diabetes, cardiac disease, and they do it very well. So I should establish myself in an area that is completely unknown, undeveloped, unincorporated into the health science curriculum. And of course, I started my journey with Prof Anton van Niekerk, with a master's in his program, and of course, exploring ethics in more detail. I remember when I wanted to enroll for this master's, Prof Pierre de Villiers called me to his office and he said, now, you already have a master's degree. You should be doing a doctorate. Why are you doing another master's degree? And I said, Pierre, and I hope you remember, it's not about the degree, it's about the knowledge. And I cannot stand in front of a 50-year medical class and teach ethics when I don't have the adequate background in philosophy to do it. And off I went. He nodded at me. He was a little bit concerned. He nodded at me, and off I went. Of course, I had a wonderful journey in the world of philosophy. And then again in 2001, I went to Pierre and said, Prof, I need to go on this Fogarty program to Columbia University in New York. And this time it's to do a master's in epidemiology. And again, he said, another master's? And I said, I'm really useless at epidemiology. I'm nowhere as good as Michael Puther. And I really need to learn or brush up on my epidemiology. And so again, half-heartedly, he let me go. Of course, it was a wonderful experience. And there I met Professor Ron Bayer and studied ethics under him while at Columbia. However, 3 days after we visited the World Trade Center, it blew up, and the rest is history. And so we lived through 9/11, and to a large extent, that put an end to my planned master's in epidemiology. However, the experience I gained was invaluable. Then, of course, on my return, I became firmly involved and committed to teaching bioethics at the university. Some people call this an oxymoron, and in my paper, I have detailed why. But I had to make a very definite decision about teaching bioethics at Stellenbosch University. Of course, in exploring ethics and its application to the medical world, we explored many important questions in philosophy, and this is Western philosophy, where Socrates, Plato, and Aristotle were the prime movers and shakers in the early days. And so the questions they raised were, what does it mean to have a good life? How does one find meaning in one's life? What is right? How do we know it is right? Of course, many of us still grapple with these questions today. To be more specific to health sciences, we need to ask ourselves, and for the past 13 years, our students have been asking, what is the purpose of medicine? And that's a really important question, especially today. What does it mean to be a good doctor? What is the meaning of a life worth living? And I'm going to come back to this point a little later on. And of course, most importantly, when are we playing God? So we're all familiar with the Hippocratic Oath. We know it's outdated. There is a great deal of controversy related to the Hippocratic Oath, and most medical students on graduation today take a modern form of the Hippocratic Oath. Of course, at the University of Natal Medical School in our days, the class of '88 was not allowed to be part of the graduation ceremony of the university, and many of us decided not to join the graduation ceremony either. So we had our own oath-taking ceremony at our campus in Kongela at the medical school itself. That was a very long time ago. Our students today learn much more about the Hippocratic Oath and other codes of conduct than we did. In fact, our flagship undergraduate ethics module runs for 3 weeks during the 5th year of training, and the students have a wonderful time because we combine fun, laughter, and enjoyment with challenging questions and important ethical dilemmas. And the students engage in what is called peer teaching, where they, at the end of the module, teach each other about important ethical dilemmas they incorporate in the hospital. Our program is designed so it is not theoretical, but that students engage practically with day-to-day ethical dilemmas that occur in clinical practice, whether it is in the public sector or in private healthcare settings. So in order to teach our students, we had to develop a book that would be locally relevant. And so it took a combination of almost 11 co-authors to put together the book, Medical Ethics, Law and Human Rights, a South African Perspective, in addition to the dental book. So the medical book has been used for the past 5 years and is currently being prepared for its 2nd edition and will be available next year. And we have had to make many changes in the new edition, and I will allude to some of them later. You've already heard about our postgraduate program. in health research ethics, where we've trained over the past 5 years 40 mid-career professionals from 10 different African countries. And so ethics has expanded from beyond Stellenbosch University into the African continent. And I'm very pleased that we have some of our graduates here with us this evening. Of course, the Center is very actively involved in empirical research, taking into account that we look not only at the science, but we look at the ethical, legal, and social issues linked to a number of scientific challenges. So, The Ethics of HIV, this particular book was written by Prof Anton van Niekerk and Loretta Kopelman. And my master's thesis on HIV vaccine challenges in South Africa was published in this particular book. So the Center has looked at the ethical issues relating to HIV prevention, HIV treatment, and more recently to proposed HIV cure research. Time magazine, a few years ago, in fact 2 years ago, mentioned biobanking as the 8th most important idea changing the world right now. Prof Johann Schneider knows that I don't know the other ideas, and I focused only on biobanking. So this is an incredible opportunity for us in South Africa. We already have a biobank established at Tygerberg Hospital, and as part of our NIH work, we are exploring important issues like consent, confidentiality, the myth of anonymity around storing samples, ownership of biological specimens, and the various challenges that we are yet to face in terms of this important scientific development. As a result of all the work we've done in the Center, we have been designated by the World Health Organization, and we've joined 6 other centers internationally. And this in itself provides a wonderful opportunity for future research in bioethics. Of course, at last I come to the tragedy of the commons. Now, people called me when my inaugural address was advertised and said, "We don't understand your topic in English or in Afrikaans." And of course, that put an end to the language debate. Anyway, what is the tragedy of the commons? So this is actually a seminal economics theory that was developed in 1968 by Garrett Hardin. And the theory, in very simple terms, was developed around farmers who were using grazing lands to graze their cattle. And of course, as a result of self-interest, each farmer tried to use the grazing land to graze more and more cattle. And of course, in the end, that led to complete depletion of this resource. So in life, we are often faced with this dilemma where individual self-interest overtakes the need to protect the common good, to protect the public, to preserve resources for the public at large. And this phenomenon of individual good versus common good is one that is really critical to our understanding of philosophy and bioethics. And as you can see, ruin is the destination to which all men rush, each pursuing his own best interest in a society that believes in the freedom of the commons. And this article was published in Science many, many years ago and reminds us constantly about short-term interests of individuals as opposed to long-term welfare of society. In fact, this article that was written by Garrett Hardin, flight that was leaving from Los Angeles, there was a patient on this flight, and of course Dr. Shapiro was in charge of transporting this French patient from Los Angeles back to France. The patient was in his late 30s. He had a condition called acute myelogenous leukemia, and he was terminal. So he was essentially going back to France to die. Now, part of his condition meant that he had a very low platelet count and was at risk of bleeding. About half an hour into the flight, Dr. Shapiro was told by the flight attendants that they had not boarded enough oxygen. However, they did offer to make an early landing in Chicago to get more oxygen on board. It so turned out that there was another patient also being transported by a second doctor. This was a lady in her early 20s with a subarachnoid hemorrhage, and she was in a coma. And so, when the second doctor heard about the crisis in terms of oxygen and the possibility of landing in Chicago, he was extremely disturbed. And he said, "This is not acceptable. My patient has a small chance of living. Your patient is definitely going to die. And so I would prefer that we did not land in Chicago." Of course, Dr. Shapiro thought very quickly about this situation and decided that it would be in the best interests of the younger patient not to stop in Chicago. He had to take the risk and make the call, and they subsequently landed in France. Both patients remarkably survived the flight, and his patient died with his family in France a few days later. But this is the type of difficult decision-making that has to occur in medicine, whether it's from several miles up in the sky or down at Tygerberg Hospital or Grooterschuur Hospital. On a daily basis, doctors have to decide which patients should be kept in ICU and which patients should be discharged to a general ward, especially when there is a poor prognosis involved. In recent times, the tragedy of the commons has become more and more important in healthcare. I have been consulted several times by members of private medical schemes who have patients in private hospitals in the ICU where it's been made quite clear that the patient's prognosis is poor, yet the family insists that the patient is treated in ICU. When it's time to step down care and the medical aid then offers to pay for home-based care, families insist on having a ventilator at home. In many cases, the cost of such treatment runs into millions of rands, often at the expense of others, and other members of medical aids then have to pay higher subscriptions. So we need to be mindful of our individual demands on medical funders, our individual demands on the healthcare system. And healthcare workers, on the other hand, need to know when enough is enough and when it is really not possible to continue treating a patient in a condition that is futile. And these are important conversations that need to happen between healthcare providers and patients, healthcare providers and families. And so, as we proceed, we find that there are many, many important challenges that we face in bioethics. And I'm going to discuss just two of them today. The one has to do with life and the other with death. And so there's this incredibly important new phenomenon called synthetic biology. It's a field of work that combines engineering with biology, with science. And it actually is so important because it ends up producing organisms, all kinds of organisms, and possibly humans too. And so this has all been made possible with a fantastic new discovery, the CRISPR-Cas9 system, which is a type of genetic scissors that is actually enzymatically able to cut the DNA molecule at various stages. Now, this is based on a system that occurs in nature, where bacteria are able to eliminate viruses from their system using this technique in a very, very natural form. So it's modeled on a system that exists in nature. It was discovered by two amazing women, Charpentier and Doudna. And of course, they are to be credited with developing the first cost-effective tool for gene editing. Of course, there are others, but theirs is retails at around $30 a time. And so this is a wonderful invention. I'm going to show you a very short video that explains it. Please don't be alarmed if you don't follow it the first time you watch it. I've watched it already almost 10 times.
Every cell in our body contains a copy of our genome, over 20,000 genes, 3 billion letters of DNA. DNA consists of two strands twisted into a double helix and held together by a simple pairing rule. A pairs with T and G pairs with C. Our genes shape who we are as individuals and as a species. Genes also have profound effects on health, and thanks to advances in DNA sequencing, researchers have identified thousands of genes that affect our risk of disease. To understand how genes work, researchers need ways to control them. Changing genes in living cells is not easy, but recently a new method has been developed that promises to dramatically improve our ability to edit the DNA of any species, including humans. The CRISPR method is based on a natural system used by bacteria to protect themselves from infection by viruses. When the bacterium detects the presence of virus DNA, it produces two types of short RNA, one of which contains a sequence that matches that of the invading virus. These two RNAs form a complex with a protein called Cas9. Cas9 is a nuclease, a type of enzyme that can cut DNA. When the matching sequence, known as a guide RNA, finds its target within the viral genome, the Cas9 cuts the target DNA, disabling the virus. Over the past few years, researchers studying the system realized that it could be engineered to track not just viral DNA, but any DNA sequence at a precisely chosen location by changing the guide RNA to match the target. And this can be done not just in a test tube, but also within the nucleus of a living cell. Once inside the nucleus, the resulting complex will lock onto a short sequence known as the PAM. The Cas9 will unzip the DNA and match it to its target RNA. If the match is complete, the Cas9 will use two tiny molecular scissors to cut the DNA. When this happens, the cell tries to repair the cut, but the repair process is error-prone, leading to mutations that can disable the gene, allowing researchers to understand its function. These mutations are random, but sometimes researchers need to be more precise, for example, by replacing a mutant gene with a healthy copy. This can be done by adding another piece of DNA that carries the desired sequence. Once the CRISPR system has made a cut, this DNA template can pair up with the cut ends, recombining and replacing the original sequence with the new version. All this can be done in cultured cells, including stem cells that can give rise to many different cell types. It can also be done in a fertilized egg, allowing the creation of transgenic animals with targeted mutations. And unlike previous methods, CRISPR can be used to target many genes at once, a big advantage for studying complex human diseases that are caused not by a single mutation, but by many genes acting together. These methods are being improved rapidly and will have many applications in basic research, in drug development, in agriculture, and perhaps eventually for treating human patients with genetic disease.
Okay, so this is fantastic science. It's extremely complex. And it's the science of today and the science of the future. It will change the history of health sciences forever. And while it might be currently being developed all over the world, especially in developed countries, it has enormous implications for South Africa in terms of the HIV burden of disease. Last year, we know that there were 6.8 million HIV-positive people in the country, 340,000 new infections, 200,000 deaths, yet only 42% of these patients have access to antiretroviral treatment. What is really important about gene editing is that it offers the possibility of a cure. At this stage, it's really very experimental, but publications are already out there investigating the possibility of gene editing as a future cure for HIV. So as science, it holds great promise. However, there are a number of ethical concerns that are arising. What about unknown harms? What about off-target effects? And if the genetic scissors works in the wrong place? And of course, there are questions being raised about scientists playing God. Not only are there scientists working in laboratories, but there are also DIY scientists working outside of academia. And these are the sources of great concern. And so recently, a group of 150 scientists had a secret meeting at Harvard to look at plans for synthetic human genomes. And of course, this is the type of conduct in the scientific world that we start to worry about. In fact, there are questions about where in the world the next CRISPR baby will be born. And of course, it's a technology that will not only produce transgenic mice, it has the potential to produce human life. And so, at what point will it be important to institute some sort of regulation around this? CRISPR has been regarded as a disruptor in science. It sounds like a bad thing, but it's actually good to be called a disruptor. I'll tell you a little bit more about that later. And so, if we look at synthetic biology as the creation of life, we also need to look at the right to death. So early last year, we had a 65-year-old advocate, Stransham Ford, who had cancer of the prostate that had spread to various parts of his body. He was terminal, he was in incredible pain. He had tried a whole host of different measures to alleviate his pain, and none of these had worked. Eventually, he made a request to the courts to end his life, and he said, "I wish to end my life with dignity, surrounded by my loved ones, while I am able to breathe on my own, speak to my loved ones, and see and hear them. I am not scared of dying. I am scared of dying in this horrible way. It is not a dignified manner to end my life." Unfortunately, the ruling to end his life came 2 hours too late, and he actually died 2 hours before the judge decided to actually to allow him the option of assisted suicide. And so, of course, this decision by the courts was strongly opposed. It was opposed by the Minister of Health, by the Minister of Justice, by the Health Professions Council, and by the South African Medical Association. And so one of the arguments they have used in their appeal is that dying should not be seen as a personal or individual affair. The death of a person affects the lives of others. And the issue of euthanasia is one in which the interest of the individual cannot be separated from the interest of society as a whole. Needless to say, some of you may be aware that in 399 BC, Socrates, the father of Western philosophy, also went through what could be referred to as assisted suicide. He was found guilty of corrupting the minds of the youth in Athens at the time, and of impiety. And the punishment was that he had to drink a glass of hemlock, which, as you can see, was handed to him. And he subsequently died, 399 BC. More recently, we've had an interesting case of a 75-year-old palliative care nurse in the UK who was completely healthy. However, she decided to end her life in Switzerland. She belongs to the Society for Old Age Rational Suicide. And she said, "I have so many friends with partners who plainly are a liability." Her thinking was that from the age of 70 onwards, one's life goes downhill. And she was not prepared to deal with ill health. Neither was she prepared to be a burden. And she chose to end her healthy life. Of course, this reminds us of a concept called senicide. It's a very old concept. And of course, we know the Eskimos, many, many decades ago, used to put their elderly out on the ice to die. And this was mainly done to conserve resources in societies for younger people. It was done in India, where elderly people were given large doses of coconut water to drink. And of course, in Japan, the elderly, especially the elderly women, are taken to a mountain and left to die. And of course, it's called Granny Mountain Dump. So, of course, when your children offer to take you to the mountain, you need to be very, very careful. So how do we reframe bioethics in this new millennium? Obviously, we face many challenges, and we need to adapt. And when we talk about reframing, it could simply be a matter of words. According to Einstein, we cannot solve our problems with the same thinking we used when we created them. And of course, the use of words is really important in life. And so I'm going to show you a very short video to see this.
Of what the saying, of different words.
Okay, so the power of language. It takes only a few words to change the way we think and to change the way we see the world. And so what are our challenges in bioethics and how are we going to reframe? So since the civil rights movement in the 1960s, the focus has been on individualism, individual rights. It's the I, me, my world. And how do we start to change that thinking to communal good and the common good? How do we move from autonomy as a principle, a very important principle in bioethics, to solidarity? Knoppers and Chadwick have written in 2005 already that it's time to rethink the paramount position of the individual in ethics. We need to be thinking more clearly about reciprocal relationships, mutuality, and solidarity, and doing things for the common good. Of course, it will take an incredible paradigm shift to do this. Part of reframing in academia, and certainly in bioethics, has been driven by the Decolonize Academia and Decolonize Bioethics movement. And so we've been teaching Western thinking. We've been teaching bioethics based on Greek philosophy for a very, very long time. However, if we consider that Socrates, the father of Western philosophy, was only 10 years old when Confucius died, we must be missing something in Confucian ethics, and yet we never go there. We barely explore what Confucian ethics is. We barely explore what Buddhist ethics and Buddhist philosophy is. And on our own African continent, we have seriously neglected African philosophy. And so we know Ubuntu as an Nguni word that is prominent throughout sub-Saharan Africa, especially in more rural traditional communities. Yet, this is a word that we fail to incorporate into our thinking. Now, Ubuntu is not equivalent to African philosophy. Ubuntu is merely a component of African philosophy. So we know the famous saying, Umuntu and Gumuntu and Gabantu, a person is a person through other persons. And it represents notions of universal human interdependence, solidarity, and communalism. It actually can be traced to small-scale communities in pre-colonial Africa. Now, we know Aristotle was a very well-known Western philosopher, but in 390 BC, Aristotle went to Egypt to learn more about the Kemetic culture and to learn more about the philosophical systems that were active in that region. And so I think we have a lot of work to do in exploring other systems of philosophy as we continue to teach bioethics. Of course, what is really important in education is creating a thinking environment, because thinking leads to innovation. and creativity. And this is what we need to survive in this millennium. It's been really heartwarming to hear students, after 10 years of teaching bioethics in this faculty, saying, I want to start by saying thank you for the ethics block. I really enjoyed it. It is one of the few blocks that makes us think and challenge. This year, the comments were equally positive. Thank you for a very insightful block, one of the best in the 5 years of my medical studies. This module encourages critical thinking within the profession and challenges paradigms. And I think of course there was a lot of negative feedback as well, as is always the case with students, but I'm only going to tell you about the positive feedback. Because when I read these comments, I sighed with relief, and I felt as if my life's work was done. I had achieved my goal. And so I hope that, like Socrates, I will not be held guilty for corrupting the mind of the youth. Bioethicists are not just academics or scientists or social scientists. We are actually here as advocates for change. We are disruptors, just like Decolonize Academia and Open Stellenbosch and the DIY scientists working out of their garages, and people like Jules Ferro, who took her life at 70, and advocate Stransham Ford, who made the first request to the courts for assisted suicide, and Tim Noakes, who's turned the thinking about nutrition upside down, and of course our very latest disruptor, Dr. Yumna Musa, who has circulated a video on sexual harassment of junior doctors in the public health system. These are the people who will change the world. And of course, challenging dogma and shifting paradigms isn't easy. And organization only really begins to learn when its most cherished assumptions are challenged by counter-assumptions. As Martin Luther King said, our lives begin to end the day we become silent about things that matter. And so as a bioethicist, I will continue to question, I will continue to challenge, at the risk of being extremely unpopular sometimes, but I have to live my life. And so far, I feel I have lived my life well. Of course, the most lasting legacy I leave to the world are my two wonderful sons, Kihar and Nikal, who have been a total joy from the day they were born to this day. They are my most valuable contribution to society, and they are the most important part of my life. I thank you for attending and for listening so patiently, and I hope that we will have some time to have important conversations in the future. Thank you.